Well, thank you so much for letting me come talk about this topic. A lot of my practice is reoperative surgery, so I have an interest in it, and I've the majority of what I've learned about this has been passing down information from the people that taught me, not so much reading in books and looking at the literature, because I think a lot of it is anecdotal. So I just wanted to take a second and just pass along to you guys what I've learned. A lot of it you may already know, but there might be some words of wisdom or pearls that people taught me that I can pass along to you that really helped me a lot. And my only disclosure is I'm a consultant for Ethicon. Um, but I'm really actually amazed when I think about it. I mean, I'm 10 years out of fellowship, and you guys really, even more so than me, have so many modalities to learn now. Like in 1 year, you have all of these things. And even 10 years ago, we had open laparoscopic robotics, some transanal techniques, but you have even more. So there's so much to learn about in a very short period of time. But I think the fundamentals would go back to knowing how to do the operations. And to me, that's open surgery. So open surgery is not the be all to end all, but I think if you can understand the operations open and the tissue planes, then you guys are so talented and can apply any modality to doing any operation. And I think that that's really an amazing thing about colorectal surgery. It's so diverse and so cool in that way. And that's why I love it so much. And when we talk about reoperative surgery, a lot of people think about it as corrective surgery. Like there's a problem, there's a fistula, there's a leak, there's something, but it's not only corrective surgery. I do a lot of corrective surgery, but sometimes reoperative surgery is just surgery on people who have had surgeries before. So that might be, doing an LAR for cancer after somebody had a sigmoidectomy for diverticulitis in the past, or a right colectomy and after an appendectomy. I listed some more here, or even it may be that you use techniques that are important in reoperative surgery for virgin abdomens. And the example I think of is maybe a person who had complicated diverticulitis and had a lot of abscesses drained percutaneously, and now you're going back to take that section of the colon out, and the terminal ileum is stuck down there, or the bladder is stuck down there. So even though that person has never had a surgery before, they have complexities in their pathology that you can use these techniques that we'll talk about to get you through those operations. And I know that there are a number of things people have been kind enough to teach me that I still think about every week, and I still hear them in my head every week. And so I just want to highlight those here to see if that might be of help to you guys. So we don't know a lot about reoperative surgery because it's hard to study. I wrote a book chapter in the last year about the frozen abdomen. And when I did a literature review just to freshen my memory and make sure I am not missing some new data, there's just not a whole lot about it. I think it's because the patients are diverse, they're difficult to study, they are hard to standardize, they're hard to randomize. So a lot of what we do know is passed down from generation to generation based on experience. But what we do know that it can be very difficult. We know that there are a lot of adhesions involved in reoperative surgery. And we also know that you can do some major damage. You can actually take a patient who's suffering a lot and make them suffer more based on what you did. And so that makes it complex, it makes it tedious, and it makes it really important for us to make all the right decisions for these patients to get through it. I thought about, why is it so difficult? Well, I think that it's difficult because of the adhesions. The adhesions are make everything hard. If you have a reoperative belly and there are no adhesions, sometimes it can be like the de novo surgery. But it can also be hard because of there's altered anatomy. Maybe there's scarring that has caused a bowel to be in places where it's not supposed to be, high in the flexures, deep in the pelvis. Can cause the ureters to become more medialized. It can cause things to be not in the place that they're supposed to be. There can be absent planes. I think about all the time the planes of the pelvis, how different it is to operate on somebody who has those nice planes versus somebody who everything is stuck together, almost like a stamp that you've already licked and put on an envelope, and you are trying to peel it back off. That never ends well. And then I put annoyances. I needed another word that started with A, and I didn't have one. But annoyances like obesity, diabetes, COPD, patient characteristics, malnutrition, steroid use, all these things that can make these operations really hard, that really don't have anything to do with the pathology at large. So how do we approach this? See, this is a typical reoperative abdomen, I would say, and I think that I would look at it and sigh or groan. But what makes it so difficult? And in reality, there are a lot of problems with this that just make it dangerous. A lot of people call it tiger territory, and we want to be able to make good decisions and have the skills to get through that to make our patients feel better. So here's a warning. The next few slides are really a very brief literature review. I don't want to lose anybody on a Sunday night, but I promise this will only be 2 or 3 minutes of a literature review. There's not a whole lot to sort of go through and think about, what do we know? What are the tangible deliverables here? What do we actually know that are data driven in this field? Because it really is not a very data driven field in my opinion. This is a study that shows basically that prior surgery, or a patient who had undergone prior surgery, it increases the operative time primarily due to the need for adhesiolysis. So we know that people who have had surgery before, you're probably going to have adhesions, and it's probably going to be a longer operation. That's pretty, I think, self-explanatory there, or we would assume that, but this is just sort of showing the data that would go along with our anecdotal evidence. This is a study that shows that it takes longer to access the abdomen in patients who have undergone prior surgery, and that these operations are usually associated with a longer lysis of adhesion. And again, these are things that we would know anecdotally, but this is putting numbers and data to that. This is a retrospective review that shows about 1 in 8 patients undergoing, in this case, abdominal wall repair, will suffer inadvertent or an aberrant enterotomy following adhesiolysis. And sometimes the longer the adhesiolysis, the higher risk for an enterotomy. And of course, that would be, we would assume that, but this is sort of putting numbers to that. And of course, as we all know, there can be a lot of morbidity to making enterotomies in these patients. Look at the difference in the outcomes with relation to lysis of adhesions. The longer the lysis of adhesions, the more likely the patient is to stay in the ICU. If they need an ICU stay, the more the medication cost, so maybe the more the care that they need, and a higher risk for wound infection, other complications, and sepsis. So all these things can support our theory that these reoperations are more difficult and more challenging. This is a study that showed that the incidence of inadvertent enterotomy is really high during reoperation, and this can have a big impact on morbidity of our patients. And this I wanted to show, look at the increasing risk for enterotomy when higher numbers of prior surgeries are present. So the more the laparotomies, the higher risk for enterotomy. And this is useful information. We can sit across from a patient and say, hey, Karen, you've had 4 laparotomies, and that means that there's a more likelihood that I might make an enterotomy in your bowel, and that might mean you may have a complication related to that. So we can have an honest conversation about what are our goals for the surgery, which we'll talk a little bit about in a second. So this is actually, I put this in, this is Cindy Kin was my co-fellow in Cleveland 10 years ago, and this was the manuscript that she wrote while we were fellows. And at that time, APL, or accidental puncture and laceration, was a big deal then, and just sort of coming into vogue. And this was showing that accidental punctures or laceration, which is sort of like serosal injury or enterotomy, is more likely to occur in complex colorectal operations. And this has an implication on it has a big implication on reimbursement and documentation. We all have to document how sick our patients are, because if they do have complications, they need to take that into consideration. So I would say, in summary, that 2 minutes tells us that adhesions in reoperative surgery are bad, enterotomies are worse, and then missed enterotomies are a complete disaster. And I laugh at that, but it's a very serious issue. we can actually take a patient that's doing quite poorly, and if we have missed enterotomies, we can make them even worse if that's even comprehensible, I guess. And the patients come in and they are suffering, and they don't think they can be worse, but we know we can make them worse. So we have to sort of take that into consideration and make sure we do the right things for them. So the aims in my mind of surgery, when I see a patient who needs a reoperative surgery, and this can be corrective surgery or just a second or third operation for something related to maybe a colorectal cancer or diverticulitis or IBD. They have to be patient specific. Every patient is different. So we want to think about the patient that's sitting across from us and come up with a plan that works for that patient. A lot of what we do is quality of life operation. You know, how symptomatic are they, and balancing that with what is the risk of surgery in that patient. And that relates to what I just said, is we can make these patients worse by going back in their belly. So are they really doing poorly, or are they just minimally symptomatic, and the risk for going back in their belly is greater than the benefit that we may afford them? And so that's a big decision to be made preoperatively. We want to minimize the risk, just like I talked about. And then overall, we don't want to hurt these patients. A lot of these patients have benign conditions that, again, you have to weigh the risks and benefits of surgery and have really honest conversations with them. Let them be a part of that process, because when it comes to quality of life, everyone defines quality of life differently. And it's not my job to define my patient's quality of life. Their quality of life may be poor. When I think about it, I might think, well, that's okay, and vice versa. So we really want to be very respectful of that in our patients. So, okay, that's all the data, but the next 20 minutes or so, I just want to talk really practically, like what information can I pass along to you guys or share with you guys that people taught me and that I learned that I use every day, that can help you through tomorrow. I heard you guys talking about what's the schedule for tomorrow, what do you have on? I want to pass along anything that I use so that you can get through tomorrow in a better way, and in your career and in your practices. A lot of you may not go into practices where you do a lot of corrective surgery, but I think these are techniques that are applicable for anybody, any operation that you do, even if it's a de novo or operation on a virgin abdomen. These are important techniques that will be very helpful. So first, I think it's important to get yourself ready. And what that means to me is that be prepared. I review old records and operative reports. I like to read those operative reports and see what's been done in the past. You can learn a lot from an operative report. I personally think sometimes the more verbose and long the operative report in, maybe the more misadventure there was. Sometimes you have to be careful about, I won't say trusting, but believing sort of what was in the operative report. I can't tell you how many times I've read, I performed high ligation of the IMA, or I mobilized the flexure, and you get in there and those things had not been done. So at least keep an open mind and be prepared for to find something different than you read about. It's important to image the patients in a practical and meaningful way to try to get as much information as you can. Number two is set reasonable expectations. I think patients can come to us with unrealistic expectations. And I think it's important to say, I really think this is an achievable goal for this operation, but taking away X, Y, and Z is just not achievable. And we'll highlight one that we all know about is pain. Pain is hard to promise this will go away with an operation. So getting to know what your patient expects and really being honest with them with regard to what you can do and how you can help them is really important. And they then can decide whether that operation's right for them. I think the example that I think about is the patients who come to us with 3 or 4 big laparotomy scars, and they say, well, I want a minimally invasive surgery. And to sit down and help them understand, what the limitations are in these situations and what you can do and can't do. And so they can make the best decisions for themselves. I think practically speaking, I remember Tracy Hull made this presentation the first day of my fellowship about reoperative surgery. And it's a principle that I've learned and I've used in my careers. These are cases that you want to start early in the day. These need to be your 7 a.m., 7:30 starts. They don't need to be your operations that you do on a day where you're running 2 rooms, or you have 2 or 3 other cases and this starts at 3 p.m. You want to get in there when you're fresh, you're not weary or fatigued, and you have everybody in the hospital that you might need. I think those are the best outcomes in these sometimes very challenging cases. It really also helps your consulting physicians. A lot of these operations are combined cases with gynecology. You might need a vascular surgeon or a urologist or a gynecologist. And I think it's just respectful to them to be calling them at 11 a.m. or 1 p.m. and not at 7 p.m. or 9 p.m. And in particular, I think about our abdominal wall reconstructionalists, our plastic surgeons or our hernia surgeons who might be coming in to do a component separation or a mesh repair. And I think that I know that their life is a lot of late afternoon or evening work, but I think it's best for everybody if you're calling them a little bit earlier so they're not coming in at 7 or 8 to start all this abdominal wall closure business. And then invite your friends. And what I mean by that is anticipate your needs. If you think you're going to need a vascular surgeon, talk to your vascular surgeon and say, on Tuesday, I'm doing this case and I might need you. Is that a convenient time for you to help me in case I need you? Or would you like to see the patient? And I promise you, you will get a lot better outcomes, but in particular, you'll make a lot more friends. And what I found is early in your career, a lot of what you do are find friends. You find friends in gynecology, urology, vascular surgery, hepatobiliary, if you don't do those things, cardiology. You find people that you can rely on to help you take care of your patients and who are not jerks. I mean, who wants to operate with jerks? You want people who are able and good surgeons, but also nice people so that you have an enjoyable career. Don't afraid to ask for help. I ask for help all the time. If I think that there's an issue that's a little bit out of my scope, I'll ask somebody to see the patient as if they might need a hysterectomy or if I might be at high risk for a ureteral injury. I have a low threshold to invite my friends and to help me. So we've gotten ourselves ready, but now we need to get the patient ready. And I think these seem intuitive or, oh, of course, Jeannie, you would, correct coags or clear the sepsis. But I think these are things that are easily overlooked and they have a huge impact on the outcome. So if you take some time to do these things in your patients, particularly your reoperative patients, they will have a better outcome. So taking the time to put somebody on tube feeds or TPN, or giving them a diet that even you could use at home, even if it's 6 boosts a day, or getting them into an exercise program, or doing some prehab. These are really important things that can help. Getting them to take iron so that you avoid blood transfusions. Those are seemingly little things that have big impacts on outcome. I almost always use ureteral stents in these operations. As we know, it doesn't necessarily mean that I cut the ureter less. It means that I identify it intraoperatively if I cut it, and I can call a urologist and have them fix it. And, the will is fixed and the train continues. That's a whole heck of a lot better than on post-op day 3, wondering why the drain output is so high. And I've been in both of those situations. And I would much rather fix it intraoperatively than find out post-operatively have to deal with it. And then I put on here, always have access to the anus. Maybe that's a good life goal. I don't know. But in these operations, even if you don't think the colon and rectum are involved, it's just easy to put the legs up. And yes, there's risk to putting patients in those positions, but I think there's great benefit to being able to scope them or instill air into the distal colorectum to help you during these operations. So think about these things when you're getting your patients ready. Timing is a big issue, and this is something that I'm very passionate about. Waiting to operate on these patients until the adhesion settle is so critical. And I know a lot of people debate this and feel differently, but what we know about adhesions is that they do start to settle after 3 months between operations. And so I really routinely, especially my patients who have had a lot of pathology or a lot of operations, we're waiting 3 to 6 months or more to let those bellies settle down before you go back. And I guarantee you this will be something that helps you tremendously. And I can also guarantee that this is a very hard thing to do. The patient doesn't understand that. They want to go back to the operating room if they have a problem that you're going to correct. The families don't understand. Let's say the patient has some stoma prolapse. The stoma nurses sometimes have a hard time if it's a difficult to pouch stoma or EC fistula, or if the patient's symptomatic. There are a lot of people who don't understand how important this is. And you're sort of left standing there saying, with a stop sign, but I promise you waiting 3-6 months or sometimes even longer between operations is so critical, and it will help you. And this is because adhesions form in that time, and it takes time to settle those adhesions, particularly after sepsis. And a waiting period also allows the patients to get healthy. They need to get nutritionally better. They need to clear the sepsis. They need to maintain or gain weight. And also, I think there's a mental component. They need to get emotionally ready. They need to increase their mental fortitude, particularly if you're going back after they've had a complication. This can be very emotionally draining on patients. And I think it's well worth the wait to get them feeling a little bit better, or as best as you can, before you go back and put them through a major laparotomy. It's important to have a plan as best you can. The more you have a plan, the more you know preoperatively, and the more you have a contingency plan, plan A, plan B, plan C, the better prepared you're going to be. So thinking 3, 4, 5 steps down the road. What if we have this problem? What if we have that problem? What if I need a vascular surgeon? And it's just a lot of preparation, but I really feel strongly that this will benefit you and benefit your patient in the outcome. One of the things that I talk a lot to my residents, because I don't have fellows, but I do have residents that go into abdominal surgery, is to have an exit strategy. And what that means to me is to have a plan in place that if you get to the OR and you try to open that belly and you have a problem and you cannot reach your goal that you had for this laparotomy, that you have a way to back out and close that patient without further hurting that patient. And some examples that I would think of is if you get in and there are varices in the abdominal wall and you lose a liter of blood just like that, or if you start to make enterotomies right and left, or if the patient is unstable. These are sometimes not the healthiest of patients, and the anesthesiologist says, I'm uncomfortable continuing. What do you do? And so always have an exit strategy. And one thing that I do is that I start away from the pathology. So I would start in the upper abdomen, for example, in this patient, away from the exposed bowel. And if I got into a lot of enterotomies or serosal injuries, what I would do is I would pull up a proximal ostomy and divert all of that and close as best I could, or the same reason for bleeding. So always have a way of getting out. Don't be in a position where you just jump right in the middle of it and then something happens and you say, I need to end this operation right now before I reach my goal, and you don't have an exit strategy. So think about that. That's in the planning and preparation part. And I cannot emphasize this enough. And if this is the only thing that anybody sort of hears during this time, backing out is never a sign of weakness. It is absolutely a sign of maturity. I can't tell you how many times I've backed out. I can't tell many times how the people who taught me have backed out, and I consider them some of the best colorectal surgeons in the world. If it's not the right time, if it's not the right conditions, get out of there, close up, divert and drain, use your techniques that you know of, and come back and do something differently, and to come back and fight another day. The disastrous abdomens that I've taken care of have in large part been a product of well-intending surgeons who have gotten way over their head, or they have tried to push and do too much in one operation. So please remember this. It's never a problem to back out. Be thoughtful about what you're doing. And if it's not the right day, come back and fight another day. And that's really a sign of maturity. Some other practical stuff that I just wanted to point out is whenever you're making an incision, make an incision away from the pathology. So on the left, this is a lady that I operated on a few weeks ago. And where I started was in the upper abdomen, away from that incision. And the reason that I did that is because in general, the that is probably going to be a location where there are minimal adhesions. And I'm able to get into the abdomen safely and establish a base or a home base. And then I go and I follow another principle I want to really emphasize in this talk, which is circle the enemy, or go known to unknown. And what that means to me is that you take an area that you have the anatomy delineated and you have a good idea of where you are, and you circle the pathology. So for example, a lot of the pathology in this abdomen was in the lower abdomen, particularly in the right lower quadrant. So I would start in the right upper quadrant or the left upper quadrant. And I'm likely to find a lot fewer adhesions in those areas, and I can delineate the anatomy, and then I circle around that area, and then I'm left with the pathology only. And I have an exit strategy. And what my exit strategy here would be is, let's say I get into a lot of bleeding, or I get a lot of enterotomies, and I say, you know what, Jeannie, this is not the right time to do it. Then I would go proximally, and I would find a wonderful piece of jejunum or ileum that I could bring up as an ileostomy, and I would drain and I would divert that patient, and I have my exit strategy. So that's a really important thing, to make an incision away from the pathology. In a lot of cases, you'll have a window where you can get started and you can get some confidence and you can get some understanding of the anatomy. Another principle is get the right exposure. I know that a big topic these days is minimally invasive surgery. The patients now come in saying, how big is my incision? I want small incisions. We're all pressed and feel the pressure to do minimally invasive surgery. And we want to do it because the patients like it. It's more cosmetically pleasing, and the patients may recover faster. But there are certain circumstances where you have to see to be able to do what you need to do. So also, don't hesitate to make a bigger incision. I see a lot of times where people have come in and had many complications after surgery, and their incision is about half the length of their abdomen. And I sort of look at that and say, I wonder what the thought process was. You know, if you get into trouble in the abdomen, make the incision bigger. And I can tell you from working with a lot of patients who have had a lot of complications after surgery, a patient would much rather have a bigger incision than a complication on the inside and a small incision. I think another principle is note the state of the tissues. Sometimes you get in the abdomen and the anatomy is okay and the adhesions are fair and you're managing those okay. But remember, a lot of these patients are malnourished, or they have COPD, or they are diabetic, or they've been on steroids, and the tissues aren't quality tissues. Maybe they fall apart in on your hands, or they're very friable. And so remember about your principles of bowel resection and bowel anastomoses. Sometimes friable bowel is not meant to be put back together, or maybe you can do an anastomosis, but you need to divert that proximally. So think about those things. Beware of the mesenteric margin when you're doing adhesiolysis. Remember that the mesenteric margin can bleed a lot, and then you either use your bovie or you put a stitch in there to stop the bleeding, and you can affect the blood supply. So be very vigilant when you're doing adhesiolysis around the mesenteric margin, because you may find yourself with some ischemic bowel or a need for bowel resection. And we want to avoid those if we don't need to in these situations, especially when people who are losing a lot of bowel or have borderline short bowel syndrome. I really like to rely on sharp dissection. There are partners of mine in other specialties who use a lot of bovie to lyse adhesions, and I would really caution you against that. Especially this year, get used to using your Metzenbaum scissors or other scissors that you like, Harrington scissors, to lyse these adhesions. I think you'll have a lot more dexterity and ability to safely lyse adhesions with the scissors. You can also use a scalpel. A 15 blade is a really wonderful thing to use, particularly when you're mobilizing the bowel from the anterior abdominal wall. So maybe practice that and use that, especially on that fibrosis that is almost always between the abdominal wall and those loops of bowel when you have really significant adhesions. I want to introduce or remind you, if you're familiar with the principle of hydrodissection. And what it simply is it's injecting saline or water between the tissue planes to help you see those planes better. And I have a video of this. You can use a like a low 20-ish gauge needle, which is shown here, or if the adhesions are softer, you can use an asepto to do this. But this is, for example, a piece of bowel that is plastered to this, I think, old piece of mesh. And if you look at it, it's hard to know where the plane between those two structures is. So I inject saline in here, and here's a video. Let's see if I can get it to work. Oh, sorry, it's so loud. Oops. So I'm injecting saline in here, and all of a sudden I see the tissue plane a lot better, and I can come back with my sharp dissection, either Metz or Harrington's or whatever you're using, and you really have a very nice plane. So think about this when you do have those loops of bowel that are stuck. A lot of those loops of bowel are stuck so much. I use the analogy of sticking a stamp to an envelope and then trying to peel it off. You end up injuring the stamp and the envelope. So this is a way to avoid that. Once you do your lysis of adhesions, make sure you check for damage. This is a situation where I've made an enterotomy and I insufflate the bowel with either saline, or I commonly use a solution of dilute betadine to highlight any serosal tears or enterotomies. It's amazing how that really can show you things that you would not otherwise be able to see. And then I put on here, repair as you go. You will forget. What that means is I will forget. Unless I repair it at the time that I see it, I will forget. And so I have to remind myself of this every operation I do. Just repair it, stop and repair it. It takes 30 seconds. And then you will feel good about making sure you didn't miss something when you go back. When you're doing reoperative pelvic surgery, one of the big complications that we can get into is presacral bleeding. I've seen somebody die of this. I've seen people get really sick or have major complications from this. So an algorithm that I learned when I was a fellow and that I use, thankfully rarely, but every once in a while when I get into presacral bleeding, this is what I do. When I identify that I have presacral bleeding from these penetrating vessels in the presacral area, the first thing I do before I even think is pack those sponges in there. You can control that bleeding with packing if you do it well, because it is a high pressure, but it's a high pressure venous system. So you'll be able to control that bleeding. The next thing I do is I tell the anesthesia team that I have presacral bleeding. If I have a resident or a CRNA or anybody that I just feel like maybe not has as much experience, ask them to get the anesthesia attending or staff in the room and just let them know as well. I think that when you're in the pelvis, if you're not on the patient's left side when this is happening, you need to pack and you need to move yourself as the person in charge to the left side of the patient. Because you have the most dexterity and the most positioning to do complex stuff on the left side of the patient. Make sure you have the right equipment in the room. That means, as we all know, our deep pelvic retractors, our lighted retractors, or a light source. And equipment might mean another partner or experienced surgeon that can help you with the exposure. And then I wanted to highlight a couple of options for control that you guys may have talked about and may have used in your experience, the thumbtack or the muscle patch. These are the lighted instruments I personally use. Some people use a headlight. I was never trained to use a headlight. These are lighted fascia retractors and lighted bright track retractors that I think give you great exposure. And they allow everyone in the operation to see and don't rely you to be looking in the pelvis like if you had a headlight, but whatever you're comfortable with, it's most important to get good exposure. These are thumbtacks. I remember a time where I heard stories about people going to the bulletin board and autoclaving thumbtacks and then using them, but you can actually get commercially available thumbtacks that actually go into the presacral space through the sacrum to tamponade on these veins. Or you can use a muscle patch. Just take a little muscle from the rectus muscle. It's no big deal. You take it off and you put it over that area that's bleeding, and you can suture it down, and the coagulation factors will help you. And then finally, have a plan to close that abdominal wall. So many people who have had surgery before may have loss of domain or hernias. Make sure that's part of your preoperative plan. If you're if you have an interest in and have the skill set to close the abdominal wall in a complex manner, go for it. I do not. I don't enjoy that, and I am not the right person. So I've got some really great hernia surgeons and abdominal wall reconstructionists that will help me, because that is a really important part. You can do a great job with the bowel, but if you can't close that abdominal wall and get good coverage of your intestine, that can be a big issue for you. And I wanted to show you one technique that I use a lot when I have a complex patient and I'm really focused on fixing the intestine, and I don't want to, or it's not in the best interest of the patient to have another 2 hours of complex abdominal wall reconstruction, or maybe they're unstable, or the the factors are not favorable for that. I do a dental roll closure of the abdomen, and this is really a skin and subcutaneous closure. You're not closing the fascia. You know you're going to have a hernia, but you get dental rolls that your ENT surgeons or your dentists use, and you fashion them in place to buttress the skin together. And this can be a very effective way to do it. I've used a really heavy Ethibond here. I've also used a nylon. I really prefer the Ethibond, even though the braided suture sort of gets a little bit gross. The monofilament suture sometimes will act as a bow on the bowel underneath the abdominal wall, and I don't love that. And I'll leave these in for weeks, and the patients will heal and they come back and they get soggy and smelly, but you know what? They have a closed abdomen. And the most important thing here is just to get good coverage of the intestine. And then when the patient gets better, or you've corrected the pathology, you come back and do a definitive abdominal wall repair with a component separation or mesh. And then the other thing that I really want to convey, and this is a very strong opinion and feeling of mine, similar to backing out is a sign of maturity, not a sign of weakness. Number two is, please consider liberal use of a covering or a diverting ileostomy or a jejunostomy when you're operating on these patients. In particular, if you're operating on somebody and you're doing corrective surgery. This is so important. And let me give you an example and reason for why I feel this way. Let's say you have somebody who had a sigmoid colectomy for diverticulitis, and they leaked and they had a fistula, and you've come back and repaired that, and you did a bowel resection because the terminal ileum was also stuck down there and you had to do that. So you've got a couple of anastomoses. This patient's already, if you think about it, probably lost 6 months to a year of their life. They've been in the hospital. They've had a lot of issues. And maybe the operation went well. Maybe the anastomoses look great. But in my practice, and what I would really strongly encourage you to consider is divert those anastomoses. You know that that's not going to prevent a leak. We all know that. But it's going to mitigate the circumstances or the complications of that leak. So these patients who you're doing these bigger operations on, they can heal on their own. And I bring them back and I do a barium or gastrographic enema or some sort of contrasted study to ensure that they've healed well. And then I close the ileostomy or jejunostomy. I would rather have a high output ostomy or an ostomy that was a little bit difficult to take care of for 3 to 6 months rather than another leak and another fistula, because then I've put that patient right back to where they started. Particularly if you think about it, when you're talking about the colon and rectum, if they leak and you have to go back and fix that, you're taking out more rectum or more colon. That's going to affect their bowel function over their lifetime. So I hear that a lot. Well, if I diverted, it would be like a really high output ileostomy. I have no problem, let me tell you, sending the patient home on home IV fluids or even TPN for a few months. And it is a lot to manage at home. But I'd rather do that and then be able to close the ileostomy and have them go off and live their life than be dealing with complications of surgery again in 6 to 12 months. So really consider this in your practice. And so I just had a few final thoughts, and most of these are sort of humorous cartoons these cartoons I borrowed from one of the really important people that taught me how to deal with reoperative surgery, Feza Rimsey, who I think has come and talked about J pouches with you, who I owe him so much. Probably my whole career is because of him, and so therefore I've stolen his cartoons. He's very, very happy for them to be shared to pass along these important things that people taught him. Vic Fazio and others taught him, and we all teach each other. And I learned so much from you guys and from everybody. So we all hear from each other. So in order to deal with abdomens like these, I think we have to make the right decisions, and the right decisions start before you even touch the patient or you even pick up a scalpel, because I think the decisions that we make in terms of planning for surgery and who we operate on can result in making good decisions and having happy outcomes, or making bad decisions. And remember, it's not us as surgeons who are taking that risk, even though it feels like it. It's the patients who are taking that risk. We're risking their health and their life sometimes by the decisions that we make, and we want to really be thoughtful with those. One of the principles that I learned early on is really think 2, 3, or really 5 steps ahead. You know, if you're doing an operation, think about, is this patient high risk for having a leak? So therefore I need to divert the patient proximally. Or is this patient, is this going to be hard to fix? So do I need to stage the patient? Do I need to put up an ileostomy first to cool off the abdomen and then come back later? Am I going to be back? Should I put some Sepra film in, or should I do something in the operation now that will help me a few steps down? Or maybe I'm not the right person who's going to come back and correct the problem, but what can I do now to make it easier, or put the next surgeon in a better shape to do the right thing for the patient? I think anticipating the worst and expecting the best is really important. Think about all the things that could go wrong and have a contingency plan for that. What if I cut the ureter? Do I have a urologist available? And that's why I think, you know, finding a urologist at 11 a.m. is a lot easier than finding one at 9 p.m. To help you reimplant a ureter. And then the principles of surgery proper, going from known to unknown, you know, starting in a location in the abdomen where you know the anatomy, and then circling the enemy or going around the pathology. Don't ever be afraid to ask. I think some of the best surgeons, in my opinion, in the world are the ones that ask people's opinions or ask for help. Just never be afraid to ask. If someone gives you a hard time for asking for help, I would just forget about them. They don't count. Surround or circle the enemy. I've talked about this before. Just start from a place where you know, and then that makes the pathology easier to delineate, or it might tell you that today's not the day to take on that pathology, and you can have an exit strategy. So that's a very important. These are things that I tell myself literally every week of my life. Known to unknown, circle the enemy, have an exit strategy. I use those every operating day when I'm taking care of these patients. And then most importantly, it is absolutely never a sign of weakness to back out of a belly that's unfavorable. I cannot emphasize that enough. That is a sign of maturity. That is a sign of experience. And again, if you're surrounded by people who are giving you a hard time for that, get new people. There are a lot of other people who would, I think, really acknowledge that that is a sign of maturity, and it's the right thing to do for the patient. So with that, I'll say thank you for letting me come. I think this is an amazing platform, and if I can ever be of service to anybody, please do not hesitate to reach out and contact me. I have done more things wrong than I have right, and I'm happy to tell you about all the things that have not worked. Those are the best lessons. So with that, thank you so much, and I'm happy to answer any questions.
Thank you so much, Dr. Ashburn, for these excellent tenets that I sure hope will be ringing in our heads when we're in the middle of a difficult lysis. Really excellent. We have some questions in the chat. First one is, Sometimes patients are very insistent about getting their fistula/ostomy taken down earlier than you would want. Are there ways in which you've been able to convince the patients to wait until the time is right that worked out better than others?
Yeah, I think that's a great point, and it's something that yeah, I think we all sort of face all the time. And I think, I would not want an ostomy for longer than I needed, but I think that there's a lot of I find a lot of help by just sitting down with the patient and saying, acknowledging what they're saying. I know you want this closed. I want it closed too. If I had an ostomy, I would want it closed yesterday. The reason that I want to keep it up is because you're still healing. This is another operation that you've got to heal. If you have any complication, we may be back to where we started in the first place, or it may be in a worse situation. So, give me a month, give me 2 months. If you show them that you're really on their side, I think that does help. I mean, there are patients that you never make happy, but I think that a lot of times the patients see that this is like you have the key to their castle and you're holding it hostage and you won't take it down. And so I think just telling them and being honest, I want you to have that ostomy close too, but more than anything, I want you to do well. I want in a year for us to look back at this year and say, I remember when I had all those surgeries and I was really sick and I was in the hospital and that was a distant memory. I don't want you to have to come back here again. Those types of things, those phrases, I think sometimes help. And the reaction usually that I get is like, okay, yeah, I get it. Or you'll get a family member or a parent or somebody, a spouse who's like on your side and helping to reinforce that. Um, the other key is I've set a date. So maybe I'm not going to budge from my 3 month, 4 month, 5 month, whatever it is, but I'll say, you know what, let's set a date. And patients do very well with dates, tangible things. And so if you book them, even if it's 3 months out, sometimes that gives them at least something to focus on. So it's not like, this abyss in the future. I would just say, make sure that date you're okay with because they're going to fixate on that date. And if you say, oh, we need to wait another week or a month, that's going to be another difficult conversation.
Great. We have several really nice technical questions here. I'm just going to go through them here. One's from our Surgeon app from Dr. Beth Ann Shaker. And she asked, when you do your hydrodissection, where do you inject? Is it the serosa?
I try my best to inject in what I would perceive to be the plane between the two structures. I'm going to tell you, there are a lot of times where I have no idea where that plane is. And so I try to aim it above the serosa or between the loops of bow. If you use like a 23 gauge or smaller, even if you do inject it into the serosa or the lumen, I personally don't think that you do any harm to injecting that into the bowel. It's not going to injure it. And so I'll inject it. And then if I want to see that little pillow of saline start. And if I don't see that, I will pull out and try another area. And then conversely, if I do see that pillow start, I'll just continue to inject. I'll reload with more saline and continue and put the needle right back into that pillow, again, known to unknown, and try to continue that dissection plane, that hydrodissection, and then cut or do the adhesiolysis. And sometimes it's inject a little, cut a little, inject some more, cut a little. If you don't feel like you're making progress in one area, go to a different area and work a little bit in that area and then come back. It's amazing how just doing a little bit at a time, sort of chipping away with it, will get it accomplished.
And then just two more questions. One from Susie Hill, one of our other CRS virtual ed leaders here. And I also had this question too. Besides looking for more dilated bowel, do you have practical advice on how best to find proximal bowel in a frozen abdomen? So when you said to get out and do that ileostomy or jejunostomy, how to that practically, go to your exit strategy?
That's a great question. And this is something that I struggled with last week because I had a lady with a big sort of exposed bowel in the middle. and she had an end colostomy from an APR, and I needed a proximal loop. And I think one of the techniques that I use is just go as high up in the left upper quadrant as you can. Now, that is not a perfect thing to do, but at least it gets you close to the DJ flexure. And then if you can find the DJ flexure, start walking that bowel down as far distal as you can. And then when you can't go anymore, pull that up. And then this lady, she's still in the hospital. I saw her today. She probably has the most proximal jejunostomy you've ever seen. And that's going to put out a ton, but that's what was necessary to divert everything downstream. She's got exposed bowel, and she's had a horrible enterovaginal fistula. Like everything that she eats goes through her vagina. So I think the technique that I would do is go as far up in the left upper quadrant as you can, and pull anything up, and then mature sort of both sides so that whatever side is the functional end is one that your enterostomal therapist can pouch. And then this lady, I had no idea what was proximal or distal, so I sort of matured both. Make sure that's really everting, because an everted ostomy of any sort is going to be easier to pouch than a flush one. In particular, when these ileostomies are going to be high output ileostomies.
Okay, great. Just a couple more for you. One of the common, this is from Dr. Avery Walker, one of the common colorectal procedures we get asked to do early on is stoma reversal. This often comes after emergent X-lapse. Can you describe your approach for the specific situation? I'm not sure if this is a specific question or this is a generic stoma reversal.
Almost all of my stoma reversals, whether they're loops or ends, I make a circle around the stoma itself, and I do a lysis of adhesions of the stoma to separate the stoma limbs from the subcutaneous tissues, and get in the abdomen that way. And I think this is really an important time where that 3 to 6 month waiting period is so important. When I was a resident, one of my attendings waited 6 weeks between stoma reversals, and he really felt strongly about it. He's a great surgeon. But then when I went to fellowship, that 3-month rule was like, it wasn't a rule, it was like a law. Like you would just lose your life if you did anything before 3 months. And having those different experiences, waiting longer, I believe it softens the adhesions. And the number of times, let's for example say a loop ileostomy, the number of times that I've had to do an X-lap to close a loop ileostomy is, I can't remember the last time I had to do that. But when you do close it at 6 weeks, I remember it was not an insignificant amount of times that we had to do a midline X-lap to do a lysis of adhesions to get that down. And so I think encircling the stoma is a good place to start. If you do run into problems and you make a lot of injuries to that limb, or you can't see, then I would switch over to a limited midline incision and lyse the adhesions that way. I think either way is a very acceptable way to do it. And just keeping in mind that the most important thing is to do it safely, whether you use a small incision or a big incision. For an end colostomy or end ileostomy, I do the same thing, because sometimes just getting into the abdomen safely through the stomal aperture can help you. And then I'll put my finger through the aperture and feel around for adhesions. And if I need to make a midline incision, sometimes that will guide me as to where to access the abdomen. I feel, one end of the midline incision. Oh, there's a lot of scarring down there. Let me fill up here. Oh, this is clear. So I know that it's more safe to get into there.
Great. So stoma first is your approach, it seems.
Mm-hmm.
Great. And then last question that both Joseph Roy Fuentes and Sam Walling have is about Seprafilm. Any real advantages to Seprafilm? What techniques do you use in your practice find helpful to reduce formation of adhesions when you anticipate that you may be back in the abdomen? Is Seprafilm really, is that helping you?
I use Seprafilm. I use it thoughtfully. I'm not somebody who puts Seprafilm on everybody. If I think there's a good chance I'm coming back, I might consider using it. I do think that although there are not data to support this, I do think that I'm aware of at least I do think that there are times where putting a bunch of seprafilm in might increase the risk for sepsis, particularly if it was a really dirty operation or a contaminated operation. I do not have good data to support that, just my own anecdotal experience and the experience that's passed on to me. I think it really does help. And so I really consider it. There are financial limitations to it. There might be hospitals that won't allow you to use it or use it sparingly. I do not routinely wrap my ileostomies with it. Like if I'm making a loop ileostomy, I've found personally that if I wait 3-ish or more months to close a loop ileostomy, in most every case, the adhesions are soft enough where I can go back and close it, successfully. But if I'm coming back to do something, I'll put it in. I don't think that really it's necessary in laparoscopic surgery. For example, I mean, the things that I'm thinking about are if you do a lap colectomy for a colitis patient, you're going to come back and do a pouch. I think that the utility is low. The scar formation is very minimal. And then there are times where you want scarring to happen. And the example that I would give is J pouch surgery. If I do an open J pouch, I want there to be scarring in the pelvis so that J pouch sort of stands up in the pelvis. And I do some reoperative J pouch surgery, and one of the more frequently seen complications is that there's nothing wrong with the J pouch, but there's a little bit of laxity in the J pouch. It just sort of flips around or accordions down instead of sticking up there. And you can have some functional problems or outlet problems, emptying problems, or you have afferent limb syndrome. So I think, my point would be is I think it's a very good tool to use. I would use it thoughtfully. I wouldn't just throw it in every case. I don't think it's cost effective to do that. You don't need it. And then there is a risk of maybe increasing the risk of sepsis afterwards. But I think it is a good product.
Okay, and we probably have time for one more quick one. Another question from Sir John from Dr. Fahim Habib. Do you use CT scan, I guess, preoperatively to determine where to enter the abdomen? Is that something that you routinely do, or is it sort of?
I don't normally scan to determine an approach. I think sometimes it's hard to know whether the bowel is up against the anterior abdominal wall, do it adhesions, or if that's just the way it's lying. I think it is very helpful for a number of other reasons. I think if I've received a patient who has had one or more operations and I don't have updated imaging, I think it's worth it to scan. You can see abdominal wall defects. You could see maybe undrained sepsis or fluid collections that maybe aren't symptomatic. If it's a patient, one common patient that I get a lot is I've had an LAR for cancer and I had a complication, a anastomotic complication. Now I want you to fix it. It's good to scan to make sure there's not a recurrence somewhere. So I think there are many reasons to have updated imaging before you go back into these reoperative bellies for all those reasons. And it can help if you have a bunch of hernias in the upper abdomen, maybe you want to stay around the belly button, or if you have some defects in the lower abdomen, that can help you. I find in general, staying in the upper abdomen is a lot safer and easier than going in the lower abdomen. I think people are thicker in the abdominal wall in the lower abdomen, and then you have the bladder to deal with, and scarring if they've had pelvic surgery.
Excellent. Well, thank you so much. I think that's all the time for this week. And be sure to tune in next week. And thank you so much. We have the recordings on Sir John and Behind the Knife. Thanks again.